All right, the neurologic system or neuropathophysiciology. Okay, this is 16 pages. So it's probably going to take me, I think, 3 hours, but we got this. I believe in us. Okay, first things first, we have to talk about the difference between arousal versus awareness, right? So arousal means that a person is just alive, right? They're kind of doing the bare minimum, but they are alive, right? So they can be breathing, they can have a heart rate. Really, those two. Really, those are the main two. So a patient could be in a coma, they could be in a seizure, they could be emotionally unresponsive, but as long as they have a heart rate and they are breathing and they are physiologically alive, then this person is in a state of arousal. Awareness is basically arousal with sentience, right? So with awareness, this patient is able to talk to you or communicate in some way. So you could be in a coma at the end of your life, or you could just be in a coma, period, but you are arousable. But with awareness, this person has to be able to, communicate, or at the very least, if not communicate, they have to have cognitive abilities. So arousal is a prerequisite for awareness. You cannot have awareness if a patient is not arousable, but you can have an arousable patient who is not aware. That's kind of how you want to think about it. So obviously, this is neuropathophysiology, so we're talking about the nervous system and what goes wrong with the nervous system. But before we do that, we have to talk about, what the nervous system even is. And it's divided into two categories: the central nervous system and the peripheral nervous system. So the central nervous system, this includes the brain and spinal cord. That's it. Okay, it's the processor. So it gives information. So the body with the peripheral nervous system gives the central nervous system. I'm going to call it the CNS just to shorten, abbreviate or whatever. But the PNS gives the CNS information. The CNS processes this information, and then they return that information to the peripheral nervous system, right? So it is the processor, and it is the main control center for processing information. And the peripheral nervous system is literally everything else, right? So your nerves in your arms, your legs, your toes, that is the peripheral nervous system. And it relies on info from the body. It relays info from the body to the central nervous system. So it's the messenger. If you touch something and it's hot, your peripheral nervous system is going to go carry that information to the central nervous system. The central nervous system is going to be like, okay, this is hot, we should move our hand. Then it's going to send it back to the peripheral nervous system. Then your peripheral nervous system is going to decide, okay, I'm going to move my hand or what. There's a whole process involved with that, and we're going to talk more about it, but that's kind of just giving you a rundown before we actually go deeper into it. There's also some basic brain anatomy that you should know, or I should know, before, the exam next week or the upper week. And the first thing is the brain, right? So we have our brain here. I kind of just copy pasted this from Google because I wasn't really I didn't really feel the need to draw out a whole brain, but there's a few, you can see there's a lot of structures, most of which you kind of should know from anatomy and physiology, but we didn't pay enough attention in that class, so I'm gonna kind of have to learn this from the beginning. But the most important things that you should know is this is the medulla or the brainstem that is responsible for your breathing, right? This is the pons. Okay, this is the midbrain. That's the corpus callosum. You can kind of see here, the corpus callosum divides the left side of the brain from the right side of the brain. And then we have the thalamus, right? And this is our pineal gland over here. This is the cerebellum. And so of course, I don't really know what most of these do because, like I said, I kind of didn't pay attention for that section of anatomy. But just as we go, we're gonna kind of tired. We're going to focus on the specific parts that we should know for the sake of the exam, or just, for the sake of life, period. And then we'll just kind of work with it as we move on. So, what do we care about? You see, we have something called the reticular activating system. That is the main character of what we're talking about today. And the reticular activating system is also called the RAS. So this is her. I have it drawn here, but that's the RAS. And this is practically our brain's on switch. Okay, this is going to keep us awake. It's going to control alertness, and it's going to help you pay attention. So if your RAS is not working, right, or if the RAS is off, there are two or a couple main conditions that could affect this, but the main one is that you are either asleep or unconscious, right? So if something is happening, right, say you smell, you're sleeping and you smell fire, or you feel something hot, your RAS is going to be activated, and it's going to signal your body, hey, you want to stay awake for whatever is about to happen, because you either have to put out the fire, or you have to run from the fire, or you have to save someone else from the fire, but you do have to do something, right? So your reticular activating system is that on switch that keeps you conscious. So no RAS means no consciousness. And think about it. What could a person be in that would make them lose consciousness? Well, that's when you're asleep, or you're in a coma, or you've been knocked unconscious for a temporary period of time. Okay, and then if you kind of tie that back into what I said with arousal versus awareness, with awareness, a person's RAS would be activated. With arousal, it would not. Okay, so that's kind of just connecting the pieces early on. So in this whole play that is your brain, right, or this show or this film that is your brain, we have two main clubs that I want you to really think about right now. And the first one is the diencephalon, and the second one is the limbic system. So the diencephalon is actually, if I come here, okay, I gotta get rid of a bunch of this stuff because I just kind of scribbled on here, but I'm gonna paint it in red. So from here, this is your diencephalon, right? So we have the thalamus, the hypothalamus, because it's below the thalamus, and then we have the pineal gland. And the pineal gland isn't labeled in this diagram for reasons unknown to me. But, yeah, I mean, I got it from Google, so that's probably why. So over here we have them. I didn't, design them yet because I said I was going to wait till I got to the explanation, talking to myself part. So the thalamus sends sensory information to the right place. It's kind of like the mailer, right? So if you touch something, if you smell something, and you hear something, you feel pain, right? That's sensory information. And the thalamus's job is to make sure that it gets to the right place. So they're the little post office guy. They carry information to the right place. All right, let's draw his hands. And he's smiling. I'd give him a little mailing bag, but I don't know if I can draw that properly. I feel like the bag should be a different color from his hands, so I don't mix that up. Okay, I think I got it. So that's his little mailing bag because he carries sensory information to the right place. Oh, okay. So thalamus, think touch and pain, right? So hypothalamus is the guy below the thalamus, and he is responsible for temperature, hunger, hormones, emotions. It's kind of think of him as the regulator. So he's like, hey, stop that. Because he regulates. I usually hate using black for my notes just because I feel like it's very unbecoming, right? Like it's very harsh. I prefer using a bunch of color. I only use black for like the characters. But he controls your temperature, your hunger, your, hormones, your emotions. So a problem with the thalamus would mean a person wouldn't be able to regulate their own body heat properly, right? And then we have the pineal gland, and this one's really easy because all she does is monitor your sleep, right? So she controls something called the circadian rhythm. I'm gonna give her eyelashes because everybody has eyelashes. And she controls, I'm gonna give her heels too, or maybe boots. And she controls your sleep, right? Or not our sleep specifically, but our sleep cycles, right? And this is like your body has an internal clock. She controls that clock. So she's the sleep giver. The hypothalamus is the regulator. I didn't give him any legs. He'll be fine. And the thalamus is the mailer. So your thalamus makes sure that sensory information gets to the right place. The hypothalamus, I didn't cross that T. The hypothalamus controls, oh, that is an L. Controls temperature. I think temperature is the most important thing here. The others, you can kind of just feel them out, but temperature is like really important. And the pineal gland is the sleep giver. Next, we move on to our limbic system, and there are two main characters here. We have the amygdala and the hippocampus. So I don't think we're going to be tested too heavily on this just because it was barely mentioned in the PowerPoint, but I find that having a broad knowledge of something kind of always tends to help you in the exams. So, accidentally gave him heart eyes. But what you do need to know is that the amygdala processes emotions like fear, and it assigns emotional significance to our memories. So if something happens to you, something scary, like you got into a car accident, or you were chased by someone on the street, or you got into a fist fight at a bar or something, your amygdala is going to assign emotional significance to it, right? So that's going to be like, oh, that was really scary, that was really sad, that was really happy, right? And then your hippocampus converts that short-term memory to a long-term memory. Also, something the hippocampus does is act as our internal GPS. That's so if someone is like easily lost, that's probably because their hippocampus isn't, doing what it should be. I like to think about how hippos can get easily lost, or how hippos are like really intelligent so they don't get easily lost. And that's how I know the hippocampus is the internal GPS. And then for the amygdala, again, that's emotion. So basically what happens is your amygdala is like, okay, so this is a sad event. And then your hippocampus stores that memory away. So when you have a problem with these two systems or these two structures, that's when you see people develop things like PTSD, right? Where they can feel the memories. They don't, like, you know what I mean? Like, there's a problem with the memories, the emotions, and the timing of the memories. Like, they can feel it. It's often feels like it's in the present and not something that happened a while back because there's an issue with this system. So, just to kind of summarize everything, we have this thing called the diencephalon. The diencephalon contains the thalamus, which is used for making sure that sensory information gets to the right place. And by sensory, we're mostly talking about touch and pain. Your hypothalamus is the regulator, so temperature, hunger, hormones, emotions. That's your hypothalamus. And your pineal gland is the sleep giver. And then we move on to the limbic system. I don't think it's labeled. Yeah, it's not labeled on here. But the limbic system is the emotions and the memory stuff. So remember that. Now, why do we care about this? Like, why am I bringing this up to you? Why aren't we going straight into the neuropathophysicology? And that is because when our body senses something, right, be it sound, touch, when we smell something, this signal that we experience goes up through the RAS, and then this tells us to stay awake, right? So it's basically like saying, hey, wake up, this is important, right? You could be feeling really sleepy, like if you're in a meeting and then, you hear a gunshot and bam, all of a sudden you're up and you're ready to go do whatever it is you need to do. That is because your RAS has told your body, okay, now you need to be awake. Now you need to be alert. This is not the time to fall off and be lollygagging. Now, that RAS tells your body to stay awake. But again, we still don't know what the signal is. We don't know. We just know, okay, we heard a noise. Okay, let me use that example. Okay, we heard a gunshot and now you're awake. That noise that you hear, we still don't know it's a gunshot. Like, right, this is all happening in milliseconds, mind you. We don't know it's a gunshot. So that sound gets passed through the hypothalamus. And what does the hypothalamus do? Sorry, through the thalamus, not the hypothalamus, my bad. And the thalamus's job is to take sensory information and get it to the right place. So if that sensory information, which is the sound you heard, gets to the thalamus is going to send it to wherever it needs to go to be processed. And then that part of the brain processes it. And so we hear it, we go, okay, so what is this? This is a gunshot. And then once the part of the brain processes it, this could be the cerebral cortex, this could be the cerebellum. I don't really know too much about that, but I feel like it's probably going to be the cerebral cortex. I don't know though. But once that part of the brain has processed the information, your limbic system will now add emotion and store this memory, right? So your limbic system will say, okay, this was a very scary event. So let's store it as a scary memory. Some people might say it was a very sad event, so we're going to store it in our long-term memory as a sad event. That is basically how your body processes things. That's why these are the main themes that we care about when we're talking about neurology and the nervous system in general. So if we have a problem with the RAS, I've already talked about this, but you're going to have coma. Right? If you're not conscious, then what are you? You're unconscious. So you're gonna be in a coma, or you're gonna be asleep. Well, I mean, you're not gonna be asleep because there's a problem with the RAS. So a problem with the RAS is a coma. If you have a problem with your thalamus, you're gonna have sensory issues because there's no mailer. There's nobody to take that sensory information and pass it on to who it needs to be passed on to. If you have a problem with your hypothalamus, you won't be able to regulate your own body temperature. You won't be able to regulate your own hormones. So it's not going to be great for you either. Okay, so now let's talk about the alterations in arousal. So obviously, if you remember, arousal is simply being alive, right? You're breathing, you have a heart rate. Everything else is kind of up for debate. But as long as you are physiologically alive, as long as someone can get a pulse on you, as long as you can breathe, you are arousal. So let's talk about the alterations in that. What could lead to you becoming or entering a state of arousal? So obviously the first one that we've been talking about a lot is a coma. What is a coma? A coma means that the brain is not awake anymore. And this is usually because the RAS is not working or because it's become impaired. What could cause your RAS to be impaired, right? This is a reticular activating system. What could cause it to go wrong? And there's two main things. So it could be a structural issue or a metabolic issue. So structural, kind of as the name implies, means that something is physically pressing or damaging the brain. If you have internal bleeding, right? This could be a subdural bleeding, intracerebral bleeding. We're going to go more into the types of bleedings later, but you could have bleeding, which is physically pushing on your brain. That's going to affect your RAS. If you had a tumor, which is physically pushing on your brain, that's going to affect the RAS. If something happened that caused your brain cells to swell or that was pushing on your brain, that is going to affect the RAS. So a structural defect means that something is physically pressing on or damaging the brain, right? It's taking up space, it is crushing the brain, and we're going to get into that later. And there's also a metabolic defect. So when you hear metabolism, you're thinking breaking down and building up and chemicals and pathways, right? And it's kind of exactly what it is. So say you are okay, but let me talk about the main definition. Right, so this is when the brain is intact, but it's not getting what it needs to function, or it is chemically suppressed. So if someone is on medication, opioids, or anesthetics, like for anesthesia, if they are on certain types of street drugs, so I'm talking morphine, weed, cocaine, heroin, anything that could depress your nervous system, that would classify as a metabolic because it's not physical anymore. Now we're talking chemicals. Now we're looking at it on a chemical level. Another thing is if a patient is hypoglycemic. Oh, I don't want to use black. If a patient is I turned off my pen. If a patient is hypoglycemic, they're not producing enough. They're not eating. There's not enough sugar. There's not enough glucose. That's what I meant to say. And if there's not enough glucose, what's going to happen? There's not going to be enough ATP. And we literally had a whole chapter dedicated to what happens when there is no ATP. There's no ATP, your sodium potassium pumps are going to fail. Your sodium potassium pumps fail, sodium stays in the cell. If sodium's in the cell, guess what else is going to go in there? Water. Your cells are going to swell. Okay? If your cells are swelling, okay, also, the cell doesn't want this to happen. What's going to happen? We're going to switch to anaerobic metabolism. You're going to see lactic acid being produced. Lactic acid means metabolic acidosis. So this is not great, okay? We don't want you to be hypoglycemic. The next thing is hypoxia, which is lack of oxygen. And again, your cells need oxygen. So that's also not good. Again, no oxygen, no ATP, all of that shit that I just said is going to happen. Then I've already talked about drugs and anesthesia. And the last thing is epilepsy, which is basically code word for a stroke, I think. Or a seizure. I think a seizure is the right, I think it's epilepsy. Yeah, it's a seizure. And when you're seizing, your brain is using up so much nutrients. It's using up so much resources. You start, instead of using about 20% of the body's glucose/oxygen intake, you start using about 60. It's exhausting on your brain. So those are the main four. Now, I talked about a coma, and I've talked about what could cause a coma, which is the RAS. I've talked about what could inhibit the RAS, which are the structural and the metabolic defects. Now let's talk about what the criteria is for a coma. Obviously, I've mentioned that something can either be pushing on the brain or it could be a chemical issue. But what actually has to happen? What actually has to take place for you to actually, your brain to shut, your RAS to shut down and say, okay, this is coma time? And there are two things. You could either have a bilateral hemisphere damage or you could have a damaged RAS. So we've already kind of talked about the RAS, right? So I'm not going to beat a dead horse. But, I will beat a dead horse because it's very important that you know this. The RAS is responsible for your alertness. If the RAS is not functioning, you will not be alert. And there are different reasons for this to happen. We just went over those, right? The structural reasons, bleedings, tumor, swelling. Metabolic reasons, think drugs, think low sugar or too much sugar, think hypoxia. Or gets too much sugar. I would say having too much sugar is way, way, way better than having not enough sugar. You know what I mean? But anyways, that's like besides the point. So that is for the damaged RAS. But let's talk about this. This one's way more important, right? It's bilateral hemisphere damage. That sounds really serious. And this is when there is damage to both sides of the brain. Both sides of the brain. So obviously I'm going to try and draw a brain, but I'm not really good at it. So this is the left lobe. I know it kind of looks like this. This is the right lobe. And then we have a little brainstem here. This is like the front view. So from the side, it looks like this. Yeah, that looks accurate. That looks accurate enough. Oof, okay. But anyways, I have a picture of a brain here. This is a side view though. So do with that what you will. And remember, this is your brainstem, your medulla oblongata. So, right. So you have two lobes in your brain, your left lobe and your right lobe. Or I guess it's your left and your right. This is my left and my right. In a patient, this would be the right and this would be the left because we're using anatomical position. But that's just me rattling off random shit that you don't need to know right now. But this is your left and this is your right. Okay? For you to lose consciousness and your RAS is still fine, there has to be damage to both this and this. Okay, it has to be the two of them. It can't just be one. Right? So if there's damage to the two of them, you will lose consciousness. There will be an alteration to your level of consciousness. Okay? Even if your brainstem is unaffected, especially if your brain, because remember, the brainstem controls the medulla, and medulla, one of its primary functions is your breathing, right? So if your two brainstems are affected, you'll be in a coma, yeah, but you'll still be able to breathe, right? Your body will still be able to breathe, but you'll be in a coma. So, yeah, and I will say it's one or the other for you to develop a coma. You don't have to have both bilateral hemisphere damage and a damaged RAS. You just have to have one, and you're going to enter a coma. But just remember, right, if you have a unilateral hemisphere damage, that will not cause a coma. Will the patient be in pain? Probably. Will they have altered levels of consciousness? Probably. Could they, will you see increased vital signs because of that pain? Most likely, yes. But will this person be in a coma because of that hemisphere damage? No. So if a patient has a unilateral hemisphere damage and they are in a coma, that should signal you that this is not a problem with the bilateral, this is a problem with the RAS. Okay? And if a patient, so just kind of keep that nuance at the back of your head. Don't let the test questions trick you. Now, how do you assess a coma? Like, what's the criteria for knowing if a patient is having a coma or if they're just like sleeping? You know what I mean? Like, how do you know? So the first thing is what I've been saying a lot is the level of consciousness. This is the number one. This is the most important thing, because if a patient is conscious, if they are able to respond to you and talk to you, that shows that most of the important stuff, the really important stuff, is working, right? It's like the top. When we were doing assessing the neurologic system in health assessment, we learned that you have to assess a patient's level of consciousness first before you go into anything else, because that'll tell you if overall the system is working. Right. So is this patient awake? Are they awake? Are they alert? Are they oriented by 4? Right? Can they respond to you? If you say hi, good morning, good afternoon, can they greet you back? That is what you want to know. Do they wake up when you enter the room? Are they responsive even when you're not talking to them? Are they, you know what I mean? That's really important. The second thing, which I want to say is the second most important, because remember, airway, breathing, circulation, is breathing patterns, right? How are they breathing? Is it unlabored? Is it, rushed? Like, is it slow? Like, can you hear them breathing? Can you see them breathing? Those are very important, okay? And that could even tell you where the damage is or how far it's gone. But we'll get into that because we're going to talk about the specific breathing patterns and what they mean in a second. Next up, we have the size of their pupils. If you flash a pen light in their eye, can they react to it? Do they see it? Not see it because, you're flashing a bright ass light in their eye, but like, can they react to this thing? Do the pupils move together? Do they move, like one moves kind of weird and then the other one moves kind of weird? Are they not moving at all? Are they contracting at the same time? Are they dilating at the same time? That's really important. And then we have the oculomotor response. And we're going to talk about how you test this. There's like some 2 really fun tests that you can do. I mean, I guess it's not fun because if a patient is, in a coma, it's not, it's not great, but it's kind of like, it's fun to practice with your friends, okay? And then we have motor responses. Can they move? Do they respond to pain? Right? If you do that sternum rub thing, are they going to respond to that? So these are the 5 main important things that'll tell you if a patient is in a coma, and it'll tell you what level of coma. So first we talked about level of consciousness, right? So let's talk about that spectrum. There's 6 main things. So the first one is confusion. And confusion is low-key like the best one, right? Because the patient is awake, but they're not thinking clearly and they have impaired decision making. So they're still fine, right? But they're just confused. Where am I? What am I doing? Why am I here? Right? Like, so they're still okay. They're still okay, but they're just a little confused. Next, we have disoriented. And this is basically if they are not AO by 4. Usually, when you want to check, when a person is losing or is becoming disoriented, they lose the time first. Then they lose the place. Then they lose person. Right? So if you want to check, if you ask somebody, hey, where are you? What day is it? And they say, oh, it's, or you ask them, sorry, not what day. If you ask them, what season are we in? And they say, oh, it's spring. We're in the spring season. And then you say, okay, where are we? And then they're gonna say, okay, I'm at the hospital. Then you'll say, okay, why are you here? And they'll say, I'm here because I was suspected for brain damage or brain trauma because I hit my head. And then you're going to say, okay, but who are you? And then they're going to say, my name's John Doe, right? So the next time you go in and ask that person, if they are losing their level of consciousness, and then you say, okay, what season is it? They're not going to remember that it's spring. They're going to be like, I don't know. But then they'll know, they'll be able to tell you, okay, I'm at the hospital for, brain damage. My name is John Doe. Usually it goes like this. But again, this is kind of just, it's not everybody is like this. Some people lose their sense of self first before they lose place and time and reason. Some people lose reason before they lose sense of self. Like it really, but that's like the general order of things. Then we have lethargy, which is kind of like tiredness, right? So the patient is tired, there's less movement and less talking, but you can still wake them up, right? So you come in and they're like sleeping or they're just kind of moping around, and then you're like, oh, hi, good afternoon. And, they're going to be like, hello, how are you? But they're going to be lethargic. They're going to be like sleepy and tired. But they're still going to be able to talk to you, have conversation and all that. Next, we have obtundation. And this is kind of like a few steps away from a coma in the sense that this patient is only awake with stimulation. So you could be talking to them and they're talking to you, and then you look away for like 2 seconds and they're back asleep. They fall asleep because you stopped talking to them. Right? And then you grab their hand and they wake up again and they say, well, why you grabbing my hand? And then you say, oh, I was just checking. You let go of their hand, you turn around to chart, and they're back asleep. Okay, so that's what obtundation is, though it's kind of a weird name. And then we have stupor. And stupor is when the patient is only able to wake up to pain. Right, so even if you say, hi, good afternoon, you scream, hey, can you hear me? Where are you? They're not going to be able to respond to you unless you perform like a sternal rub or you pinch them. Then they're going to like jump up and be like, huh? What? So kind of think about it how alcoholics, if somebody's like truly, truly wasted, you could be literally screaming and shouting to them like, hey, get up. And they're not going to listen until you like slap them across the face or something, right? So that's stupor. And then we have the final step, which is a coma. So in a coma, there is no response to pain, or there is a very little response to pain. And how well they respond to pain will determine if this is a light coma or if this is a deep coma. So if there's no response, then they are in a deep coma. If there's a light response, then they're in a light coma. So when I say pain, there are different ways you could test this. So first we have the sternal rub. I think that's like the most popular. The other one is the eyeball push, where you put your hand on their eye and you kind of push it inwards. And apparently it kind of hurts. So they're going to wake up and be like, yo, why are you pushing on my eye, dog? And then you have, okay, so like I said before, there are 2 reasons you could have a coma. 1, your RAS is not activated. 2, there is bilateral damage to your hemispheres, right? So if it's not, it has to be one or the other. It doesn't have to be both. Okay, now let's talk about breathing patterns. So I said, how a person breathes will tell you where that damage is, right? So this one, we have post-hyperventilation apnea. So this is directly tied to having low CO2. And remember, the only way the body can clear CO2 is by hyperventilating. So if you have a patient with low CO2, that means that this patient is hyperventilating. Okay? So, hyperventilation apnea means that a patient is hyperventilating. So they're going like, okay, and because they hyperventilate, they clear their CO2. So now you are respiratorily alkalotic, right? Because there's low CO2. And because of this low CO2, the brain is going to be like, yo, we are losing way too much carbon. Like, we can't be doing this shit, dog. And so they tell you to stop breathing for a while. So it'll be like, and then you just stop breathing. But then you start breathing normally again after a while, right? And then you go back to your but because when you stop breathing, now there's going to be way too much CO2 and your body has to clear it off. So you're going to go again, and then you're going to have to way too little CO2, and then your body's going to be like, okay, stop breathing. And then you're going to go and then you stop breathing, and then the CO2 gets too high, and then you got to start doing it all over again. It's a rough cycle, man. It's a rough cycle. So something important you should know about this is that the blood gas will vary. Okay? If you take it when the person has just finished hyperventilating, they will be respiratory alkalotic. If you take it midway through their apnea, right? So when they're like they stop breathing to kind of like clear the CO, to kind of, let the CO2 levels rise, you might see a normal blood gas, or you might see respiratory acidotic. If you take it towards the end of the apneic phase, you're definitely going to see respiratory acidosis. So if you have a patient who is, experiencing post-hyperventilation apnea, you want to make sure that you, as a nurse, note when you are taking the blood gas, right? You should say, okay, I'm taking this blood gas while he's hyperventilating. I'm taking this blood gas while he's in his apneic period. I'm taking this blood gas when he just started the apneic period. You have to be very specific so you don't scare whoever has to read the message. So, next things next. Oh, also, I'll talk about that later. Next, we have the Cheyne-Stokes breathing. And this is basically, first it's fast, right? Then it's slow. Then it stops. Then it repeats. So it's like... So kind of like that. And that's pretty much the Cheyne-Stokes breathing. Then we have something known as central neurogenic hyperventilation. So this is when the patient is just fast, deep breathing. There's no pattern. It's just nonstop, right? So the patient is just like But the thing is, because central neurogenic hyperventilation happens over a long period of time, we're talking weeks, months, years. I don't know if it goes up to years, but, for the sake of my example, this person's body will have compensated for the respiratory alkalosis. How will they compensate for that? They'll compensate for it with metabolic acidosis. Okay? So that is central neurogenic hyperventilation. Then we have a stage known as apneusis. So this is kind of when you take a deep breath in, you hold it for like a really long time, and then you take a deep breath out. So you're going... You know what I mean? That is called apneusis, and that's not good, right? A patient with this is they're getting really close to the danger zone if they are not already in the danger zone, okay? And then we have cluster breathing. So this patient just takes random breaths. They're just like, and then they stop, and then they take a random breath again. Like you don't really know with cluster breathing. They just breathe, and then they stop, and then they breathe again, and then they stop, and then they breathe again, and then they stop. Like you can't really know too much. And then we have ataxic breathing, which is the last stage of your breathing. Well, it's not the last stage. It's like the second to the last stage, technically. And this is basically completely random. There's no rhythm to it. Right? The patient breathes sometimes they breathe, sometimes they don't breathe. You know, they have periods where it's just no, it's really bad. And then we have the last one, which is agonal gasping. And this will signify end of life. So with this, you're going to hear weird agonal sounds, and you're also going to hear rhonchi because their lungs aren't expanding enough when they inhale. So it's gonna be like, you know how people are dying and then like in movies and then they start like gasping for air. That's kind of like what agonal gasping is. But because it signifies end of life, we don't really classify it as an abnormal breathing pattern because this patient is probably already dead or close to dying. Weeks, days, hours, like minutes, hours, days, a day max. But yeah. So, like I said, you can tell a lot about a patient's where the damage is by the patient's breathing, right? So if they have post hyperventilation apnea, this is a cerebral hemisphere problem, right? It's still up. It's up here. Wait, where's that picture? That picture is coming in way more handy than I thought it would, but it's like up here. So that's like, it's still very much salvageable. There's still a lot you can do. Shine-Stokes is the same thing, right? Because they're kind of similar. The only difference is that for post-hyperventilation apnea, there is no period of slow breathing. But for Shine-Stokes breathing, you can see fast, slow, stop, repeat. Fast, slow, stop, repeat, right? But for post-hyperventilation, it's fast, stop, fast, stop, fast, stop, fast, stop. So they're both in the cerebral hemisphere. However, central neurogenic hyperventilation, and this is different because it lasts a long time. So a lot of times the patients will be doing just fine. They won't even come in unless they have like a serious issue that they're like, okay, now I have to come in for whatever problem they have. But, you know, the patient will come in for something, and then you'll be like, hey, your breathing is kind of weird. And this will signify a damage to the midbrain. Now, remember what I said about that being where the, that kind of controls your breathing, the midbrain? Yeah, so here. And that signifies damage to your upper pons. So that'll be this area right here, okay? And that is central neurogenic hyperventilation. That's this guy. And then here, apneusis will signify damage to your middle pons. Okay, so remember the pons is that ball thing that's just kind of there? So it'll be the lower part of the pons. Okay, and then the cluster breathing is damage to the entire pons. The entire thing is gone. Right, because again, it's in stages. It goes from, you go from this to this to this to this to this to this and then to this. Okay, so it's in stages, right? It kind of it gets progressively worse the more you go. Okay, and then ataxic breathing means that the whole brainstem is failing, the whole thing. Agonal breathing means the person's like, they're close to the end of their life. So also, we're supposed to talk about pupil sizes and reactivity and what each pupil size could mean. But that slide was low-key kind of confusing, so I decided not to really go into it, and I just kind of left it alone. Feel free to go check it out or watch a video that kind of just summarizes that. I don't really know what to do about that slide, so yeah. But when it comes to pupil size and reactivity, what you should know is that your cranial nerve, what cranial nerve am I thinking about here? Okay, the third cranial nerve, okay, that is called CN3, carries parasympathetic fibers, right? So if you have some kind of swelling or bleeding in your brain, this cranial nerve is going to be crushed. And if it's crushed, then those parasympathetic fibers that's on it won't be able to carry those signals to the eye. And your PNS, the parasympathetic nervous system, remember, this is your rest and digest. So it tells your pupils to constrict. So if you have, what am I thinking of right now? If you have a patient whose pupils are overly dilated, that would mean that the parasympathetic nerves are not there, right? Which means the SNS is able to fully run rogue and do its thing, right? But, yeah, I know. I know that you know what I'm talking about, so I'm not going to stay on that too much. But, okay, so for this, something I did find really interesting, and it's more than just interesting, you do have to know this for the exam, is something called the oculovestibular. So there's two main tests. That's what I was telling you about, right? That we're gonna talk about the tests it's fun to do with your friends. Yeah. So that's the oculovestibular test, and then we have the oculocephalic test. So the oculovestibular test is something that will test the integrity of the brainstem and the functioning of the inner vestibular system. So eye, vestibular is ear, right? So you're going to whisper in the ear. You're going to put something in the ear and you're going to look for movement in the eyes. Okay? How does this work? Well, first off, you have to raise the head of the bed. Okay? You don't want to do this when the patient is lying flat. That's not going to help you or the patient or anybody. I'm going to raise the head of the bed, get about 50 cc's, that's so 50 milliliters of warm water, and shoot it in the patient's ear. Now, usually, what's supposed to happen is that the patient's eyes will move towards the affected ear. So this will tell you that the brainstem is intact because the cranial nerves are working together. The abducens, the vestibulocochlear cranial nerve, those two guys are working together. It shows that the brainstem is able to, transmit all these pathways and whatnot. Okay? If both of the eyes move towards the affected ear, so wherever you're shooting that warm water into, there's going to be called a conjugate movement. Okay, conjugate means you conjugate together, you move together, right? If only one eye moves, then it's a disconjugate movement. So if a patient has one eye, only one eye moves to the site of the stimulus, that is disconjugate movement, that is abnormal. It doesn't matter that, just one eye. No, it's abnormal, right? If there's no movement at all, that is abnormal. The only thing that is considered good and normal is when both eyes move to the right direction. And the right direction is whichever ear you shot that warm water into. Now, you don't need to know this part for the exam, but like I said, anything could help you on that test, right? And so when I was doing research, I found out that it doesn't just have to be warm water. It could be cold water as well. But the thing is, if you shoot cold water into the patient's ears, then their eyes have to move away from the stimulus to the opposite direction, because nobody likes cold water, apparently. Okay? Next, we have the oculocephalic test, and this is actually called the doll's eye test. And that's kind of cutesy. It's not cutesy because this is people's lives, but, the name is cutesy because how you do this is you're going to do this to see if the eyes can maintain a midline position when your head is turned. You know how when you move your head side to side, your vision doesn't like randomly change. It kind of carries through. And that's because when you move your head, your eyes remain midline. They shift, they adjust to stay in the midline, right? So, it is not done on people with a cervical or spine injury because you're going to be turning this patient's neck really, really fast. You want to make sure that they don't have any issues. You don't want to damage any of those cranial pathways, any of the, what's it called? The spinal, C5, C6, any of those cranial nerves. You don't want to damage those. So you want to make sure they don't have a cervical or spine injury. And you're going to open up the patient's lids, lightly put your hand on the top, and then you're going to turn their head. And their eyes should move to maintain a midline position. If they do, that's good. If they don't, that's bad. Again, if you see a disconjugate movement, that will signal to you that it's also bad. And if this test does not work, that means that there is damage to the brainstem and that the nerves are not able to cooperate with each other. Again, same thing for this. If this test does not work, that means there's a damage to the brainstem and the nerves are not able to cooperate with each other. All right? Okay. Now let's talk about motor response and posture. So we kind of, so this is where we are right now, here. So we have two main things to talk about. We have decorticate and decerebrate. So we kind of talked about this in health assessment, but let's go a little deeper as always. So decorticate posturing means that the hands and the upper extremities are flexed, which means they're going inwards, and the feet and the lower extremities are extended, which means they're going outwards. And this basically indicates a damage to your cerebral cortex, which is above the brainstem. So think of corticate for cortex, right? And your decerebrate posturing means that the arms are extended and the legs are extended. So I like to think about how decerebrate has this E and this E. So extended by 2. So there's decerebrate has 3 E's, decorticate only has 1, right? So the 3 E's tell you that there's 2 extensions, your hands and your lower extremities. Decorticate will only be 1 extension, which is your lower deformities, and the upper one will be your hands. And the decerebrate will signify that there is damage to your brainstem, and this is not what we want because your brainstem controls your breathing, right? If a patient cannot breathe by themselves, they might as well be dead. Okay, that's not good. Okay, now let's talk about 2 distinct types of mental illnesses is what I want to call them. I'm pretty sure there's a better name for them. So the first one is delirium. And delirium is basically when there's a sudden fluctuating change in the mental status caused by acute brain dysfunction. It happens fast, usually over 2 to 3 days. So delirium means that something sudden happened to your brain, and all of a sudden you're acting crazy. Now, there are 2 main reasons you could experience delirium. The first one is if you have a change in your neurotransmitters, either there's an increase or a decrease, you will experience delirium. The second one is if inflammation messes with the blood-brain barrier, and that'll also lead to delirium. Now, with delirium, the patient's ability to focus is usually the first thing that gets affected. So you see things like decreased concentration, insomnia, trouble. And the thing about delirium is that it's reversible. Whatever caused these neurotransmitters to be affected, whatever thing, if you fix it, it can go back to the way it was before. They can go back to being functioning, right? So what could lead to delirium? People who are stressed right? People who are going through withdrawals from alcohol, from drugs, people who are post-op because, they were just under a lot of anesthesia that could have messed with the brain. ICU patients are heavily sedated all the time, most of the time, I mean, not say all the time, so that's not good for them. People who are sick, right, or stressed because inflammation, right? You don't want to be sick because of inflammation. You don't want to be stressed because that could increase, the cortisol levels and whatnot. So, a lot of stuff could lead to delirium. Now, when it comes to delirium, there are three main types. We have the hyperactive delirium, and here you see that the patient becomes agitated, restless, and they are sometimes aggressive, right? They can have signs like tachycardia, tachypnea. They might have a fast heart rate. They might be breathing really fast because they're really angry, and they might have an increased blood pressure. Sometimes patients even experience like superhuman strength because of the sheer level of delirium of whatever they're facing, right? Usually, right, all these things that I've mentioned, which part of the nervous system does it sound like? It sounds like the sympathetic nervous system. So usually we have hyperactive delirium as a result of an overactivated ANS. This specifically systemic nervous system, right? So if a patient is taking drugs, if the patient is on alcohol, or if they just came out of surgery, they can be in a hyperactive state of delirium. Then we have the hypoactive, and this is when the patient becomes, pretty much the opposite. They're withdrawn, they don't want to speak to anybody, they're less responsive, and sometimes they're even excessively sleepy, And so a lot of times, and this kind of sounds like the dream patient, because they're not going to bother you, they're not going to call you for anything, really. And so it's very easy to miss them, which is why you have to be really careful to make sure that you're always comparing your patient's baseline. If they were really chatty in the morning and all of a sudden now they don't want to talk, this could be a sign of something under the surface like hypoactive delirium. Okay? Next we have mixed, which is kind of when the patient will fluctuate between being hyperactive and being hypoactive. I like to think of it as Rue from Euphoria, in the sense that 1 minute she'll be like screaming, throwing shit at her mom, beating her sister, all of that. And then the next minute she's like in a pool, in a puddle of tears, and she's just crying and she doesn't want to be near anyone. That's kind of how I like to think about delirium, right? Because Rue in that period was undergoing withdrawal, and withdrawal is one of the main causes of delirium, right? So if a patient is going through that, you're likely to see these characteristics in this patient. Now, as the brain, now, when a patient is deliriumic or deliric or delirious, I think that's the right word for it, the brain will continue to misprocess information. And so patients will usually experience things like restlessness, irritability, and peripheral disturbances like hallucinations and delusions. So patients with delirium, patients on alcohol withdrawal, medication withdrawal, patients on opioids, patients on anesthesics, these patients could also experience hallucinations. They might hear stuff, see stuff, interact with stuff that does not exist, right? And then we have dementia. And see, the main difference between delirium and dementia is that delirium is acute. Delirium is reversible. Delirium happens within 2 to 3 days. Dementia is not, okay? So dementia is the slow, progressive breakdown of brain function over time. The brain will gradually lose its ability to function properly due to ongoing damage at a cellular level. It is not caused by a change in level of consciousness. So the patient is usually awake, but thinking, memory, and behavior is impaired. So with delirium, they have altered levels of consciousness. They might be tachypneic, they might be tachycardic, but then you're gonna be like, "Sir, what's your name? Where are you? Who are you? What time is it?" And then they might not be able to answer you, right? Because they're deliric, right? They might be in a sense of stupor. You know what I mean? But with dementia, the patient is awake, and they're just not alert. They're just not oriented to who they are. They're not, their behaviors might be impaired, people with dementia. So what could cause dementia? Well, we're not really too sure. But the two main things is, the first thing is abnormal protein production and inflammation, which is usually what causes anything. And then we have repeated injury. So things like strokes or trauma, head trauma, this can cause you to get dementia. Okay? And any of these two, whether it be abnormal proteins, inflammation, or repeated injury, will lead to cell death, which will cause the brain to shrink, which will decrease your synapses. And synapses means the communication between neurons, right? So if there's less neurons, then less neurons are communicating. And if less neurons are communicating, then you have a decreased synapse, which means you're not processing as much information in enough time. Okay, now, with dementia, we have a clinical manifestation. Obviously, the clinical manifestations for delirium is going to be an altered level of consciousness and altered level of behavior. With dementia, however, we're going to see memory loss. First, it's going to be their recent memory, then it's going to be their long-term memory. So they might still be able to tell you, what they used to do 10 years ago, but then they won't be able to tell you what they had for dinner 30 minutes ago. You know what I mean? Next, we're going to see a decline in thinking. The patient starts having poor judgment, trouble reasoning, and the inability to problem solve. So you're going to ask them, hey, what do you want to do? Or you just ask them a random question, and then they'll exhibit poor reasoning, poor judgment, and inability to problem solve, right? And then you'll have behavioral changes. So personality shifts, confusion, sometimes even inappropriate behavior. So a patient with dementia can reach out and try to grab you inappropriately or something, and that's because they're just not right up there. Okay, now let's talk about the key differences between delirium and dementia. Delirium is sudden, right? It's sudden and it is reversible. Dementia, it is not sudden, right? It's a steady decline. It can happen over weeks, over years even. It is progressive. It gets worse as time goes on, and it is permanent. With delirium, if you take away whatever it is that's causing this person to be acting up like this, so if it's alcohol that this person needs, you can give them alcohol. If this person is doing this because they're in the end of life, then you can try to treat that for delirium, right? But with dementia, you can't treat it. Well, I mean, you could slow down the progress sometimes and whatnot, but it is permanent. It is progressive. It gets worse. If nothing is done, it'll get worse as days go by. Okay, and I'm going to take a break right now, and then we're going to move on into Alzheimer's disease. Okay.